Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning. Partial skull.
We're going to center our attention today on a skull procedure, and I'm actually going to focus on a partial skull procedure. More and more CT is taking over these exams, so for you to see a partial skull, you know, it may or may not happen, but you need to know the basics. And a partial skull would consist of an AP axial. Some techs who have trained in previous years may refer to that as a town. Newer textbooks will refer to it as an AP axial. And then we will do a lateral. For a full procedure, you would do an AP and a PA, an AP axial, and both laterals. That would be the difference. So we're going to focus now on our patient. We actually have a patient who's cold, so we put a blanket over her, protected her reproductive organs. I have a 10 by 12 cassette in the Bucky tray with the ID towards the caudal end of the table. Supplies I have out will be my left marker, a sponge in case I need it, and calipers are a good trick for beginning students to have available. I have my tube transversely centered, and I have 40 inches to the Bucky tray as preliminary setup here. We're going to look at an AP projection first, and one of the first things that you have to do is you have to look at the orbital meatal line, the OML line, orbital meatal line. And you will look for the ear and the channel, the external auditory meatus, and the outer canthus of the eye. And you can see that that is not perpendicular. It's at an angle. We're going to end up having her tuck her chin, and I'll use these calipers. Now, with an injured person, you're going to want to be careful. A pen might be more convenient here, but something with the straight edge, when you're first starting, you can use this device to help you decide just how far that head needs to be tucked. Just a little, okay, we're happy now. But if somebody's injured and you hit this table, the noise can be excruciating. So just be careful if you do happen to choose calipers. Some straight edge when you're first beginning is a great idea in order to help you visualize that orbital meatal line to be perpendicular. Okay. The film's edge should be 2 inches above the vertex of the skull. You can put the calipers at the vertex of the skull and then center the film that way. So you've got the 2 inches clearance. Or another trick that I like to use, because our shapes of our skull can be so different, I'm going to find the vertex of the skull, the base of the skull. I can feel the mastoid tip there, and I divide the skull in half. Here's the top, there's the bottom, and halfway is where this crosshair should be. So I fixed my film. I'm adjusting my tube to exit to the center of the film, and I'm analyzing this particular patient's skull shape. Here's the vertex. There's the bottom of the skull, and you can see that this crosshair is just a little bit low, and I like my skulls being centered. So instead of having the 2 inches above, I'm going to adjust that centering just a little bit to put the cranium right in the center of the film. Now, if you cannot palpate the skull, pain, bleeding, fracture sites, those are reasons that you would not actually find the landmarks yourself. Using the film's edge 2 inches above the vertex is a perfect solution. The skull may not be perfectly centered, but you'll have good clearance and you will not clip pertinent anatomy. Center your anatomy when you can do so. If not, use these reference points that we're telling you. Okay. I'm going to switch my position here for just a minute. I'm going to push the cassette in because everything's lined up. Again, the tube is transversely centered to the center of the film. And I'm going to come to this end of the table. And I've got to have our MSP to the center of the table. MSP stands for mid-sagittal plane. And basically what that is, it's the reference line dividing the skull into equal left and right halves. Okay. Okay. Now, again, I want the orbital meatal line perpendicular. I showed you some tricks to do that. Once I knew that I could tuck her chin, then I centered the skull to the film this way. And then I come to the head of the table and I center the skull this way. That gets your anatomy to the center of the film. The last thing you need to do is make sure there's no rotation. And I'm looking at the MSP. It serves as a centering reference line and it serves as a positioning criteria line in that the mid-sagittal plane needs to be perpendicular. It needs to be straight up and down. I'm going to let the camera realign its position right now so I can better explain that concept to you. Okay, the camera has realigned itself so you'll be able to see what I'm demonstrating now. But when I'm at the head of the table, the camera's at a slight angle so you won't have the exact perception that I have. But you'll walk to the end of the table and you look down on the patient's face. Okay? Let's look down at the patient's face. And I'm evaluating the MSP to make sure it's perpendicular. It's centered, first of all, then it must be straight up and down, must be perpendicular. I'm going to purposely offset her skull a little bit here. And I want you to look at the outer canthus of the eye out over the zygoma here. And you can see that there's a lot more width on her left side than on her right side. Okay? That would let me know that the MSP is not straight up and down, that the MSP is tilted. You do not want that. You want the MSP straight up. So when I go to the head of the table, I'm going to look at this distance. I'm evaluating the space between the outer canthus and imaginary plane and looking down to see if that width is equal on both sides. That will let me know that the MSP is indeed perpendicular. Okay? Okay. We're almost done with the AP skull, so let me kind of review again what we did. We had the patient tuck her chin in order to get the orbital meatal line perpendicular. I put the film's edge 2 inches above the vertex of her skull, but because I could palpate the edges, I found the mastoid tip in the vertex and centered that cranium. Then I positioned myself to the head of the table like I am now, and I made sure that the crosshair was coming down the center of the mid-sagittal plane. And then I looked at the distance from the outer canthus of her eye to the lateral aspect of the skull to make sure that distance was equal on both sides to verify that the MSP was indeed perpendicular. Drea's skull is smaller. You can see the light on the tabletop. And actually the gauge says this is just shy of 10 by 12. Well, her skull is small enough to where I can bring this collimation in that way and side to side, making sure I clear the anatomy. So you can see a little bit of light on the tabletop. And I'm doing that on both sides, making sure I'm not clipping pertinent anatomy. And then I will place the left marker on her left side inside the collimated field here. Okay? And I think you can see that marker within the shadow there. Okay, tight collimation, the skull size will actually dictate how tight you can collimate on that. And then you would make your exposure. Okay, we're going to let the patient relax for a minute and we'll do some talking. You notice that I had my patient in a recumbent position. A walkie-talkie type patient, you'll be doing these at the vertical board. The reciprocating buckies and the details that you can get from the grids on upright units now is phenomenal, and most techs are doing these in a vertical position. You must be flexible enough to do these either in a recumbent or a vertical position, because a patient who's going to faint on you, you cannot sit them up. You have to lie them down. We're just beginning our skull unit, so I'm going to show you in the recumbent position, but I would do exactly everything the same at the vertical position, and the rest of our demonstrations will be at the vertical board, so you'll get to see both ways. Make sure you have your lines memorized and your PFRs memorized, and you should not have a problem producing the skull radiographs that we're talking about. There's going to be many times that a patient cannot tuck their chin in order to get the orbital meatal line perpendicular. So I put a trick out here for you. I have a positioning sponge, and we're going to kind of try to mock it with Drea. She's fairly flexible, but it's hard to hold, so we're just going to kind of let her offset her orbital meatal and pretend she can't tuck her chin anymore, and you can see how it's not perpendicular. Let's say she can't tuck her chin anymore. Well, I'm going to raise her skull up and put a sponge and see how that is adjusting the orbital meatal line. So your sponges are going to become a great positioning tool to help you out in situations like this. If you end up with too much OID, in theory you should raise your SID. For every inch of OID, it's approximately 1.5 inches of SID. If you adjust your SID, you will recall from image production that you will need to adjust your mass levels, increasing them using the density maintenance formula. Drea, can you think about anything else for the AP skull? Okay. We'll go on then to our AP axial, often referred to as the town, the gentleman who designed the position. But in boards, we're getting away from the names of people, and we will be referring these as AP axials. Patient is in an AP position. In fact, the skull is in the exact same position that it was for an AP. The axial denotes a tube angle, and in this case we're going to have a 30-degree caudal tube angle. The skull, again, remains in the exact same position. I'm going to remove the sponge and just let Drea relax for a second while I change my film, put it back in the exact same position, ID blocker to the bottom, and I'm going to set my tube at a 30-degree caudal tube angle. With a 30-degree caudal tube angle, 5 into 30 is 6, so instead of saying the gauge saying 40, it's going to say 34 in order to maintain my 40 inches SID. So I'll be back. I have our patient set up pretty much for us to accomplish our AP axial position for a skull procedure. I will remind you that our patient does not have any false teeth, earrings. I actually would be a little bit concerned about this choker for this particular projection because the tube is going to throw things down. So I might remove this necklace. Contact lenses, if possible, should be removed, but that's not always the case. Definitely eyeglasses will need to come off. So we're going to focus on our AP axial now. Remind you we have a 30-degree caudal tube angle. We will have a 30-degree caudal tube angle with the orbital meatal line perpendicular. I've mentioned on our AP that sometimes it's difficult for a patient to get the orbital meatal line perpendicular. You can use a sponge to accomplish that. And if you can accomplish that with an AP axial, what you can do is have a 35-degree caudal tube angle. So I'm going to talk to you about that in a minute, but let's kind of look at what we've done here. Again, I have a 30-degree caudal tube angle. I want my orbital meatal line perpendicular so my patient tucks her chin. Again, use the tricks if you need to with calipers. The gauge says 34, but it's actually 40 inches SID. I enter at approximately the level of the hairline. Remember, everybody has different hairlines. So it's approximately at the hairline. More importantly, I'm exiting through the mastoid tip. Central ray is at an angle, and I'm exiting through the mastoid tip. The film's edge will be level with or up to 1 inch below the vertex of the skull. And in this case, we have the film's edge about 1 inch below the vertex of the skull. When you're using calipers or some kind of straight edge, make sure you come off at a straight angle when you evaluate your film's edge. And then I'm going to pull the tube off transversely centered so you can see actually where it's exiting on the cassette here. Now, this is an exception to the rule. 99.9% of the time, this central ray should exit to the center of the cassette. But in the case of a skull and the vertex, we're afraid of the vertex being clipped, this central ray can be like up to about an inch below the center of the film. I like where it exits on this patient. It's exiting through the mastoid tip, and this is well within the acceptable range with the film's edge 1 inch below the vertex of the skull. Okay. I'm going to focus on the MSP now. Again, it should be centered and it should be vertical. So I need to realign myself. This is what you would do as a tech. Make sure your tube goes back to the transverse center. And the MSP is to the center of the film. And again, I'm looking at the canthus of the eye, the outer canthus, to the lateral aspect, making sure that she is not rotated. And I do want her straight on the table or else it will be tilted. You need to check your collimation to make sure it's clearing the skull. I have a little bit of light on my fingers above her vertex. Side to side, the width of the skull will dictate. I'm looking at both sides to make sure that light clears it, and then I'm making sure my L marker is in the center. And that is your AP axial. Okay? Now, I mentioned what if the patient cannot get their OML perpendicular. If the OML is perpendicular, that tube should be angled 30 degrees. Okay? I don't know if that's actually 30. I'm just giving you kind of a picture what to think about. If the OML is not perpendicular, they can't tuck their chin, that would be the OML. Maintain that 30-degree relationship with the OML. Well, if the OML is off vertical by 5 inches, that makes that 35 inches. If it's off 10 inches, maintain that 30-degree relationship, so the tube angle actually would be 40 degrees. So in essence, the bottom line is be 30 degrees from the OML. Hopefully the OML can become perpendicular and you can set that 30-inch or 30-degree cephalic tube angle. And 10 by 12 film, ID to the bottom. Film's edge should be level with or up to 1 inch below the vertex of the skull. MSP should be to the center. And I want the MSP perpendicular. That will put the distance from the outer canthus to the lateral border of the skull equal on both sides. And that's our AP axial. I'm going to demonstrate the PA position projection for the skull next. But I will remind you that it is not normally part of a partial skull series. It is considered to be a projection of the complete skull series. So again, your departments, they'll have established protocol. Make sure you know what projections are required for partial skulls or complete skulls. Sometimes a partial will be ordered and sometimes a complete skull might be ordered. So we're going to go back to our patient now. A PA is basically opposite of an AP. And in doing so, we need to have our patient tuck their chin, put the forehead on the table, and I want the orbital meatal line perpendicular. She needs to tuck her chin a little more. And notice how she moved her arms up here. Sometimes it's better to have the patient's arms up by the skull, sometimes underneath, actually underneath the chest or off to the side. Breast tissue on women can affect the pain level. So pay attention to the need of your patient and you might readjust their arms. Whatever you do with one arm, you do with the other arm. Okay? So again, I'll hold her hair up and I think you can see the orbital meatal line is perpendicular. Make sure you get off to the side, not like I was with the camera for demonstration, but actually physically you be in alignment with that line. And then I'm going to go to the head of the table make sure the MSP is centered, and the film's edge, you can use the film's edge being 2 inches above the vertex. We talked about that earlier with the AP. Or you can find the base of the skull and the vertex of the skull, which Andrea works out again that it would be better if I used these 2 landmarks and centered the skull and had more than the 2 inches above, because her skull is not very long. And exiting to the center of a 10 by 12 cassette, ID towards the caudal end again. This left marker here will go on her left side inside the collimated field in the end. But I'm going to go to the head of the table, and I'm getting her skull centered side to side, putting the MSP to the center. Okay. And now the trick is, Tex will do multiple tricks. You can feel the sides of the skull and make sure that relationship is the same. You can actually get down, and the camera can focus in on this. And what I'm doing is I'm finding a bony landmark, and I can feel the mastoid tip on both sides, and I'm making sure that they are the same height from the table. In other words, if she was rotated, see how my hands are going to be at different heights? You don't want that. You want to have the skull not rotated, and that means the mastoid tips would be equal distance on both sides. Some techs will feel the auricle of the ear, just in front of the EAMs, and again evaluate the height in order to make sure there's no rotation. You can't look at eyes because they're hidden, so you have to feel for some bony landmarks. Collimate. And place your marker inside the collimated field, but not into the skull. My marker's over here left. I could use a right over here if I wanted to. Okay? Again, have the patient's body straight, hands in an equal position, up, down, under the chest, orbital meatal line perpendicular, mid-sagittal plane perpendicular, and then you center the skull, and you center the skull. And that would be a PA. The PA on a radiograph is going to look very, very similar to an AP. Let's kind of recap our positioning. First of all, the skull should be centered to the film. In Drea's case, the vertex will be more than 2 inches from the film's edge because she has a shorter skull, but I can look at the cranium and it is centered, and I've got the skull centered this way and I've got it centered that way. So I did a good job of getting the MSP to the center of the film and centering the skull this way. If I made sure that her MSP was perpendicular on a radiograph, your PC information, the positioning criteria, you would actually look at the outer canthus of the eye and measure the distance to the lateral borders of the skull. If that is equal on both sides, there was no indication of rotation, and that tells you that the MSP was actually perpendicular. Okay, what about the OML? OML was this motion. Okay? If the OML is perpendicular to the plane of the film, the petrous portion will fill the orbits. Okay? Will fill the orbits. If the petrous is not filling the orbits are high, petrous is low, that means you need to tuck the chin more. Or if the petrous ridge is not filling the orbits, okay, I've got to think this through a minute. I think I already said that. If the orbits are high and the petrous is low, you need to tuck the chin. Once in a while, when you shoot the x-ray, you could actually have the chin tucked too much, and the petrous would be beyond the orbital ridge. And if that's the case, you need to elevate the chin. The AP will look just like the PA because the positioning is exactly the same. with one anatomical structure difference. Do you remember the theory of OID, object image distance? Think about the orbits. With the skull in an AP position, the orbits are away from the film. You have quite a bit of OID. The orbits will look bigger. With the PA, the orbits are closer to the film. The orbits will look smaller. So if you're comparing an AP to a PA, look at the size of the orbits, and you'll be able to determine which one was AP or PA. AP axial, if the orbital meatal line is perpendicular with 30-degree caudal tube angle, the dorsum celli will be projected into the foramen magnum. And side to side now, you're not going to have the orbits on an AP because the orbits are thrown down. You're going to look at the symmetry of the petrous portion, and you're going to look at the distance from the foramen magnum to the lateral borders of the skull, and you make sure those are equal on the two sides. The last projection we have to do, position, is our lateral. I'm going to only show you one. I'm going to actually show you a left lateral, which would be the preferred lateral projection. Then her skull can be facing you. A partial series would consist of one lateral. A full series, you would do both laterals. But for today's lesson, we're only going to demonstrate the one. So I'll get things set up and I'll be back. We'll focus our attention on the lateral now. If you look at the Bucky tray, you'll see that I have changed the shape of the cassette to a crosswise mode. It's the same cassette size, 10 by 12, crosswise. ID blocker will actually be towards the patient's face. Okay? The patient is in an LAO position. Left arm is down to their side. Right arm is tucked up. It can actually be under her chest. She's more comfortable. It can be out to the side here. And then the right hip is elevated with the right knee supporting the leg, and I readjusted the lead strip. Okay. Before I actually tweak on my patient here, let me tell you what lines I'm going to focus on. I'm going to focus on the inner pupillary line, and I'm going to focus on the MSP again. Okay. The inner pupillary line will be perpendicular to the table, and the MSP will be parallel. Okay? And I need to squat physically down and look at my patients straight on in order to get those reference lines in the positions that I want. Once I get them in the positions that I want, I need to move quickly to get that cranium centered. Again, I'll shoot for the film's edge being 2 inches above the vertex, but I'm going to find the cranium edges. I'm going to find the vertex and the base of the skull, divide that in half, and just center the cranium in cases like Dreas where I can actually find the borders. Okay? So we're going to kind of readjust here for a second. Okay? And I think you can see me now. Drea has quite a bit of head drop here. And if I tried to wrench on her, I just know I'm going to make her uncomfortable. So I'm going to point something out right now. I don't want you reefing on a patient's skull. There's a better way. If you come in under her chest here, see the chin is angling down. If we elevate her neck, see what it does to the chin there? And perhaps I might need to put a sponge. Again, it depends on the patient's chest size, but I may have to put a sponge underneath there to help elevate that. But then the chin doesn't have such a big drop, and then I can just have her look up at me, and I don't have to reef on the skull as much. Again, it's so much easier if you come into the neck region. Okay, see how it elevates that chin. Okay, I'm going to focus on the IP interpupillary line first. Okay, tuck her chin. And I'm getting the interpupillary line perpendicular. Again, you can use a pen or some kind of straight edge to make sure you get that relationship. And then the MSP is right here. And if she's looking down, you don't want that, and you don't want her looking up. So I'm going to look at the canthus of the eye to the lateral aspect of the zygoma and make that equal on the two sides. And there I'm happy with the lateral position, and then I move quickly because this is not comfortable for her to hold. I might put a sponge underneath her chin if I need to for mobility reasons. I'm finding the top of the skull, the bottom of the skull. I'm centering it this way. Top, bottom, center this crosshair. Back of skull, front of skull. This is basically coming right down the sella turcica, just a little bit in front of the EAM. My collimation, I've changed the shape of the collimation because it's a manual collimator. It's 10 by 12 crosswise, and I'm making sure that I'm clearing the skull. I have plenty of clearance so I can actually collimate in a little tighter because her skull is fairly small. Making sure I have some light clearing the vertex. And then I put my left marker down over the mandibular area. And I'm not putting it all the way into the light source, but at least 3/4 of it will show up there. Okay? And that's a lateral projection. We're actually going to let her relax, and I'll review the concepts with you again. Okay? You need to position the skull with the interpupillary line perpendicular. And you need to look at the space between the canthus and the lateral aspect to make sure the MSP is parallel. Try to follow me here now. If her skull, if the MSP is tipped, you'll see less distance, more distance, or vice versa. That will actually shift something forward and something back. And when we get into film critiques, you know we're going to be looking at the TMJs, we're going to look at the sella tursicas, we're going to look at the orbital roofs, we're going to look at the EAMs. If those structures are not lined up in an anterior-posterior position, if something is forward and something is back, that will be your indication that your MSP was not parallel. Whereas the interpupillary line, if it's not perpendicular, one will be high and one will be low. One high, one low. Think of those structures, and if those structures aren't lined up in the same vertical plane, if one is high, one is low. Again, the EAMs, the orbital roofs, the TMJs. If one is high, one is low, that meant your interpupillary line was not perpendicular. And then the skull gets centered. Center that cranium. Film's edge 2 inches above, and this crosshair should be coming right in front of the external auditory meatus, approximately right down through the sella turcica. 10 by 12 crosswise with the ID blocker towards the mandibular side, using an L or R marker. Left lateral, use the left. Right lateral, use the right. Generally speaking, you will do mostly left laterals, but if somebody took a blow to the skull on the right side, yes, do a right lateral, because you know that it's better to, the side that you're most interested in is better to be closer to the film. You have less OID that way, and your resolution is better. And there's our partial skull with the PA thrown in, almost a full skull series. Okay, thank you.